daripada CRT. Nah, guidelines ESC pada dasarnya sama dengan guidelines daripada Canadian di step pertama. Step pertama, dia menyatakan bahwa sejawat mempunyai ejection fraction 40% atau less than 40%, mulailah dengan quadruple, bukan triple terapi ya, yaitu adalah ACE inhibitor, kemudian ARNI yang posisinya di sini masih menggantikan ACE inhibitor, kemudian beta blocker, MRA, dan tentu saja SGLT2 inhibitor dalam hal ini adalah DAPA ataupun EMPA. Dan setelah itu sejawat berikan secara simultaneous, kemudian dengan dosis yang kecil, lalu diaptitrasi. Nah, step kedua, ini yang menarik agak berbeda dengan Canadian. Step kedua dari guidelines ESC menyatakan, jika pasien masih symptomatic, ejection fraction 35% or less than 35%, sejawat boleh pikirkan ICD. Atau kalau QRS-nya lebar dan terutama LBBB, sejawat boleh pertimbangkan untuk pemberian CRT. Namun kalau ejection fraction udah lebih dari 35% nih, tentu saja devices menjadi tidak indicated. Nah, setelah itu baru sejawat lihat secara fenotipe pasien sejawat masuknya mana nih, pemberian ivabradin kah atau pemberian vericiguat, atau kalau misalnya setelah pakai devices masih ada symptoms, maka sejawat boleh pikirkan fenotipe sesuai dengan pemberian terapi sesuai dengan fenotipe pasien sejawat. AHA sebenarnya mirip seperti ESC, cuman di step pertama memang mereka lagi-lagi 4 obat secara simultaneous, yaitu adalah ARNI ataupun ACE inhibitor. Memang ARNI diposisikan lebih awal dibandingkan dengan ACE inhibitor pada guidelines AHA. Yang kedua adalah beta blocker, ketiga MRA, keempat adalah SGLT2 inhibitor, dalam hal ini adalah empagliflozin ataupun dapagliflozin. Dan step kedua, ini yang menarik adalah setelah dioptimalkan sesuai dengan toleransi daripada pasien sejawat, dilihat bagaimana ejection fractions-nya. Let's say kalau misalnya masih kurang dari 40%, sejawat boleh lanjut ke step selanjutnya. Tapi kalau ejection fraction ada more than 40% atau yang kita kenal dengan heart failure, improve ejection fractions, what we should do? Lanjutkan obatnya, jangan ragu-ragu, lanjutkan obatnya, jangan kita stop. Dan ini sudah jelas sekali dengan level rekomendasi 1 seperti yang dikemukakan dari guidelines ACC AHA. Lalu di step ketiga, kalau misalnya ejection fractionnya 40% or less than 40%, baru sejawat harus pikirkan kemungkinan penggunaan devices, sama persis seperti guidelines European. Nah, selanjutnya di step terakhir, tentu saja kalau pasien itu masih symptomatic, sejawat boleh pikirkan pertimbangan obat-obatan sesuai dengan fenotipe daripada pasien sejawat. Lagi-lagi heart rate more than 70, sinus rhythm, sejawat boleh pikirkan ivabradin, atau pada pasien-pasien yang memang terindikasi untuk pemberian vericiguat, bisa kita berikan vericiguat kalau misalnya di luar negeri, sementara di Indonesia belum ada, semoga suatu hari nanti akan ada. Nah, kalau kita lihat guidelines ESC 2021 dan ACC 2022, prinsipnya sama yang di kotak merah ini. HFrEF, ejection fraction 40%, less than 40%, 4 pilar harus masuk, unless contraindicated. Jadi nggak lagi berdasarkan symptoms guided. Begitu sejawat mempunyai pasien dengan ejeksi fraksi 40% atau kurang dari 40%, berikanlah keempat obat pilar tersebut, kecuali ada kontraindikasi. Start low dose, that's the most important thing. The priority is start low dose simultaneously, then uptitrate based on your patient's tolerance ya. Nah, yang menarik lagi dari guidelines ACC di sini adalah mereka satu-satunya guidelines yang memberikan rekomendasi kapan sih kita harus meningkatkan atau secepat apa sih kita harus meningkatkan obat-obatan gagal jantung kita. Itu adalah 1-2 minggu. Guidelines ESC tidak memberikan level rekomendasi walaupun mereka memberikan saran yaitu adalah 2 minggu biasanya. Canadian pun seperti itu. Namun yang menarik di sini adalah memang HCCAH yang sudah memberikan rekomendasi 2A untuk meningkatkan obat-obatan gagal jantung. Seperti yang dikemukakan baik itu dari Canadian, European, ACC, mereka tidak memberikan secara jelas rekomendasi apa sih yang harus kita masukkan terlebih dahulu. Nah, oleh sebab itu kita harus bertanya kepada para ahli. Ada 2 di sini yang menarik. Yang pertama kali dikemukakan oleh Profesor Green, yang ternyata mereka menyatakan bahwa kalau kita mau memberikan keempat obat itu dalam 1 hari, walaupun bukan dalam satu waktu, tentu saja dalam 1 hari, ambil contoh berikan ARNI dan beta blocker di pagi hari, kemudian MRA di siang hari, kemudian ARNI dan SGLT2 inhibitor di malam hari, itu bisa dilakukan. Dan tentu saja keuntungan adalah 4 obat itu bisa langsung masuk ya, dan meminimalisir kemungkinan clinical inertia. Tetapi yang harus kita pikirkan nggak semua pasien mungkin bisa diberikan seperti itu, karena ada 2 dari 4 obat yang berpengaruh terhadap blood pressure. Dan kalau timbul adverse events, mungkin kita akan bingung, ini disebabkan karena obat yang mana ya? Nah, itu memang kerugiannya. Nah, yang kedua adalah yang dikemukakan oleh Prof. Rosano. Mereka menyatakan bahwa based on your patient's profiling, what is your hemodynamic of your patients, bagaimana kidney functionsnya, bagaimana rhythmnya. Ini memang more tolerable dan more applicable dalam clinical practice, tapi memang akan ada resiko untuk terjadinya clinical inertia. Jadi satu sama lain mempunyai keunggulan dan kerugiannya masing-masing. Namun key concept of sequencing heart failure medications, know your patient's profile, itu yang paling penting. Kalau pasien dengan blood pressure yang mepet-mepet mungkin akan sangat sulit untuk kita memberikan keempatnya secara bersamaan. Yang kedua adalah prioritize obat-obatan yang sejauh pikir akan memberikan benefit lebih. Dan tentu saja yang tidak kalah penting adalah specific regulation. Seperti di Indonesia, BPJS kita tahu 3 obat terlebih dahulu, seperti apa yang juga direkomendasikan oleh Pokja gagal jantung. Mulailah dari ACE inhibitor ataupun ARBs jika pasien tidak bisa mentolerir ACE inhibitor, beta blocker dan kemudian MRA. Setelah itu baru pikirkan kalau pasien masih simptomatik kita ganti ACE inhibitor menjadi ARNI. Dan kemudian kalau memang kita berdiskusi dengan pasien memungkinkan untuk memberikan SGLT2 inhibitor, maka kita berikan SGLT2 inhibitor. Apapun sequencing heart failure medications-nya, prinsip utamanya adalah dapat mencapai heart failure goals terapi. Apa sih goal terapi daripada penderita gagal jantung? 1. Penurunan mortalitas. 2. Prevensi heart failure hospitalizations. 3. Yang tidak kalah pentingnya adalah improvement clinical status, functional capacity, dan quality of life. Dari studi ternyata hanya 4 kombinasi, yaitu adalah ARNI, beta blocker, MRA, dan SGLT2 inhibitor yang secara signifikan mampu menurunkan all-cause mortality, cardiovascular mortality, or heart failure hospitalizations. Ya. Dan memang kalau kita lihat dari ke-9 profil nih penderita gagal jantung, kita lihat bahwa SGLT2 inhibitor yang di warna hitam ini adalah obat yang direkomendasikan kepada penderita heart failure reduced ejection fractions yang masuk ke dalam 9 profil. Karena kita tahu bahwa SGLT2 inhibitor baik itu dari hasil Emperor Reduce ataupun DAPA HF secara jelas mampu menurunkan cardiovascular death and heart failure hospitalizations, dan in terms of heart failure hospitalizations dia juga bahkan bisa menurunkan kemungkinan kejadian heart failure hospitalizations di ICU atau CICU, dan juga mampu menurunkan secara signifikan kemungkinan heart failure hospitalizations yang membutuhkan inotropes, vasopressor ataupun mechanical support ya. Dan yang menarik lagi, bukan hanya in terms of heart failure hospitalization dan cardiovascular mortality, tapi ternyata SGLT2 inhibitor dalam hal ini adalah empagliflozins mampu memperbaiki NIHA functional class 30 sampai dengan 40% lebih baik dibandingkan pasien yang diberikan placebo, dan juga menurunkan kemungkinan deteriorisasi daripada functional capacity atau clinical status dalam hal ini adalah NIHA sebanyak 40% dibandingkan dengan pasien yang diberikan placebo. In terms of quality of life, ternyata memang kita lihat di sini based on KCCQ, pasien yang diberikan empagliflozins dalam 3 bulan, 8 bulan, dan 12 bulan secara konsisten mampu memperbaiki quality of life pasien. Dan kalau kita lihat satu persatu terutama in symptoms frequency and symptoms burden, yang dimana itu menjadi salah satu hambatan bagi seorang pasien gagal jantung untuk menikmati hidup ya. Jadi sangat penting hal ini. Bagaimana in terms of karakteristik dari pasien itu sendiri? In Asian populations ternyata signifikan kok, tetap sama ya dalam hal ini, dalam hal menurunkan heart failure hospitalizations dan juga dalam hal menurunkan cardiovascular death ya pada penderita yang diberikan empagliflozins. In terms of age, less than 65, more than 65 years old, signifikan menurunkan. Dalam hal laki-laki ataupun perempuan, signifikan menurunkan. Body mass rendah ataupun tinggi, signifikan menurunkan. EGFR rendah ataupun tinggi, signifikan menurunkan. History of heart failure hospitalizations juga signifikan. Background daripada terapi pasien itu dengan ARNI sekalipun tetap bisa menurunkan secara signifikan. And there's no time to delay. Why? Karena kalau kita berikan empagliflozins dalam waktu 12 hari itu sudah bisa kita dapatkan manfaat dalam hal menurunkan cardiovascular death dan heart failure hospitalizations, dan signifikan until 34 days dan seterusnya. How early? Dulu mungkin sangat sulit ya pertanyaan ini untuk dijawab. Kapan sih secepatnya bisa kita berikan SGLT2 inhibitor? Saat ini sudah ada EMPAL study. EMPAL study ini pada prinsipnya memang memberikan empagliflozins pada penderita yang masuk dalam perawatan karena heart failure, tapi ada syarat. Kalau sejawat mau memberikan sesuai dengan EMPAL study, memulai empagliflozins, syaratnya adalah Patients-nya ini harus punya blood pressure setidak-tidaknya 100 mm Hg. Yang kedua, no inotropic support dalam jangka waktu 24 jam. Yang ketiga, no symptoms of hypotension. Yang keempat, dia dalam waktu 6 jam terakhir itu tidak boleh ada peningkatan IV diuretic dose. Dan yang terakhir, tidak mempergunakan IV vasodilator, termasuk di dalamnya adalah nitrates. Nah, at the end of the day, ternyata EMPULSE dengan analisis statistiknya yang menarik ya, win ratio of clinical benefit, dia selalu menang empagliflozin dibandingkan dengan pasien-pasien yang diberikan placebo dalam hal menurunkan cardiovascular death and heart failure hospitalizations. Walaupun kita tahu bahwa memang belum masuk guidelines karena kita harus menunggu hasil daripada studi lainnya. Kalau kita berbicara, ini saya ambil dari salah satu presentasi dari Profesor McDonough yang menyatakan bahwa kita udah tahu nih semua benefit daripada SGLT2 inhibitor, dalam hal ini kita berbicara empagliflozin, tapi seringkali juga ada adverse events yang menjadi kekhawatiran daripada para klinisi. Memang itu adalah sesuatu yang tidak bisa kita hindari karena clinical trial participants itu adalah the healthiest of the sick. Ya. Lalu yang kedua, trialist experience in GDMT administration itu biasanya orang-orang yang memang sudah sangat pakar dan biasanya juga heart failure consultant. Dan yang ketiga, in the real world data, biasanya pasien-pasien kita itu adalah pasien-pasien dengan multiple comorbidities. Jadi memang adverse event itu memang lebih sering muncul biasanya. Namun data yang ada menyatakan bahwa empagliflozin, kalau kita lihat di sini, ternyata dia tidak menurunkan blood pressure pada pasien dengan blood pressure yang rendah. Atau bahkan dia menurunkan tapi pada pasien dengan blood pressure yang tinggi. In terms of genital infections, ini juga selalu menjadi kekhawatiran para klinisi. UTI bisa kita lihat bahwa tidak berbeda signifikan. Genital tract infections, ya memang empagliflozin lebih tinggi. Tapi yang terpenting adalah tips and trick. Kita perlu edukasi pasien kita untuk selalu menjaga higienitas daripada alat kelaminnya, dan saya rasa kalau di Indonesia sangat kecil ya kemungkinannya karena kita terbiasa menjaga higienitas. Kemudian sebenarnya kalaupun timbul itu bisa diatasi dengan lokal terapi. Kemudian kalau berbicara tentang volume depletions, ya emperor reduce dan DAPA HF juga menunjukkan memang ada penurunan atau volume depletions tapi tidak signifikan. Dan basically baik itu emperor reduce ataupun DAPA HF itu kedua-duanya mempergunakan diuretik. 80% daripada pasien yang diinklusi itu mempergunakan diuretik. Yang menarik adalah diuretik yang timbul pada SGLT2 inhibitor itu ternyata lebih banyak mengeluarkan interstitial fluid daripada blood volume. Jadi ini menarik sekali. Jadi sejauh tidak perlu terlalu khawatir terkait hal tersebut. Penurunan eGFR memang terjadi dan memang sesuatu hal yang bisa kita prediksi. Saya rasa sejauh sudah paham betul akan hal ini. Penurunan ini murni diakibatkan karena hemodynamic response atau yang kita sebut salah satu postulated mechanisms-nya adalah tubular glomerular feedback. Yang terpenting adalah sejauh kalau memulai empagliflozin, berikanlah pada pasien dengan eGFR setidak-tidaknya 20. Lalu apa? Monitoring. Karena prinsipnya obat ini kita tahu dari empakitni, kita tahu dari DAPA CKD. Sebenarnya obat ini sangat baik untuk ginjal dan bahkan nefrologis pun mempergunakannya. Yang terpenting adalah monitoring. Jadi jangan takut selama kita berikan pada eGFR 20 ataupun lebih, yang penting monitoring. Kalau tidak ada penurunan lebih dari 40% secara sustain, tidak ada penurunan kurang dari 15, tidak ada penurunan kurang dari 10, tidak ada chronic hemodialysis ataupun renal transplant, maka sejawat boleh berikan terus. Jadi bagaimana? Oke dok. Jadi bagaimana caranya kita menghindari terjadi worsening renal function dan bagaimana caranya kita menghindari kemungkinan volume depletions? Assess volume status pasien sejawat. Hipovolemik, turunkan atau stop diuretiknya. Jangan langsung men-stop SGLT2 inhibitor. Euvolemik, berikan saja langsung. Hipervolemik, naikkanlah dosis diuretiknya. Jadi yang kita mainkan adalah diuretik. In terms of hypoglycemia, jangan takut, terutama pada penderita non-diabetes, jangan takut akan kemungkinan hypoglycemia. Karena kadar gula di dalam darahnya saja sedikit, yang terfiltrasi otomatis sedikit, sehingga yang terbuang juga sedikit. Sehingga penurunan A1C hampir pasti bisa kita ketahui tidak akan terjadi. So what to check before initiating SGLT2 inhibitor? Kontraindikasi, adakah kontraindikasi? Cuma ada 4 kok kontraindikasinya, tidak sulit untuk kita hafalkan. Lalu yang kedua adalah cautions ya. Ada beberapa hal yang harus kita perhatikan untuk memulai SGLT2 inhibitor. So basically SGLT2 inhibitors are easy to use, few contraindication, single dose, no need for up titrations, minimal effects on heart rate and also blood pressure, renal protective in long term, dan memang ada penurunan eGFR tapi ini lagi-lagi adalah suatu proses hemodinamik. So the take home message for my presentation today, unless contraindicated, all patients should receive foundational therapy with 4 pillars. The priority is to start low dose of all drug classes together or simultaneously. Initiations and titrations should be individualized. Pahami betul-betul karakteristik pasien sejawat. Lalu SGLT2 inhibitor, dalam hal ini kita berbicara empagliflozins, can be easily incorporated into clinical practice for patients with HFrEF, even across ejection fractions. Dan terutama nanti kalau kita berbicara tentang PEF, will be discussed by Professor Sim. And due to its consistent and favorable efficacy and safety profile, empagliflozins can be used across broad range of patients. We know patients with low BMI, high BMI, older age, younger age, or whatever the EGFR, actually these medications is safe. And kalau kita balik lagi ke judul daripada presentasi hari ini, SGLT2 inhibitors, knowing in HFrEF management, is it enough or is it not enough? Seperti yang dikatakan oleh Dr. Riri, what next? What next? Just implement to your patients. That's all. Okay, thank you so much.
Terima kasih, Dr. Maya. Maaf, saya lupa kita ini bahasa Indonesia ya ternyata.
Yes.
I'm sorry, Professor Sim, for the first two speakers, since you are quite aware of Malay, so we're going to deliver the first two lectures in Bahasa, and we're going to do the Q&A after your lecture in English as well. Jadi yang presentasi kedua, Dr. Hari, beliau adalah, Dr. Hari, tolong saya. Beliau adalah kolega saya, sama-sama di divisi kardiologi klinik dari FKUI. Dan Dr. Hari saat ini bertugas di Rumah Sakit UI sebagai kardiologis dan clinical cardiologist dan juga di divisi heart failure. Dr. Hari akan bicara mengenai susahnya kita mendiagnosis HFpEF. Silakan Dr. Hari, 2 menit.
Oke, terima kasih Dr. Riri. Assalamualaikum warahmatullahi wabarakatuh. Morning, all my dear colleagues and Professor Sim. So yeah, like Dr. Riri said, I will try to present my presentation using bahasa. Kita akan bicara banyak mengenai diagnosing atau berdiagnosa HFpEF based on clinical phenotypes. Kenapa sih? Karena HFpEF ini maksud challenging ya, sangat susah. Kalau misalkan tadi HFrEF kan sudah jelas dengan fungsi jantung rendah, itu sangat mudah. Sedangkan HFpEF ini fungsi jantungnya bisa dikatakan sebenarnya normal. Sehingga kita membuat jadi bingung nanti ini karena apa heart failure-nya, karena heart failure atau karena penyebab lain. Karena itu kita kembali lagi sebelumnya, kita definition of heart failure apa? Heart failure adalah suatu sindrom klinis yang disebabkan oleh suatu gejala seperti shortness of breath, sesak, ada ortopnia, ankle swelling, yang juga disertai bisa juga suatu tanda peningkatan jugular venous pressure, ada Rales pulmonary crackles, ada tanda S3 dan peripheral edema, yang semuanya biasanya harusnya disebabkan oleh adalah gangguan struktural atau gangguan fungsional dari jantung berupa peningkatan tekanan intrakardiak dan atau penurunan dari cardiac output saat istirahat maupun saat olahraga. Jadi itu dia pegang. Jadi sindrom klinis ya untuk heart failure. Kedua, ini untuk HFpEF sebenarnya tetap kita memerlukan data ejection fraction karena sebagai klasifikasinya ESC ini mengklasifikasikan heart failure berdasarkan ejection fraction menjadi 4. Yang pertama tentu saja yang sudah diterangkan oleh Dr. Maya tentang HFrEF, di mana ejection fraction kurang dari 40%. Lalu yang kedua adalah widely reduced dengan ejection fraction 41 sampai 49%. Dan HFpEF ini akan kita bicarakan hari ini, yaitu adalah dengan ejection fraction lebih dari 50%. Karena dia lebih dari 50%, maka sebaiknya disertai dengan tanda-tanda cardiac structure abnormalities-nya dengan konsisten dengan LV diastolic dysfunction, dengan tanda elevated LV filling pressure dan elevated natriuretic peptide. Atau yang terbaru itu adalah improve EF, tadi sudah dijelaskan oleh Dr. Maya, saya kira saya nggak perlu jelasin lagi. Kenapa HFpEF kita perlu bicarakan nih? Karena proporsinya makin lama semakin meningkat. Ya, kalau dulu kita ini jantung hanya dengan fungsi jantung rendah, sekarang makin meningkat. Kurang lebih sampai lebih dari 50% sekarang peningkatan new onset HF itu mulai banyak adalah subset yang HFpEF. Dan proporsi pasien-pasien yang masuk rumah sakit juga meningkat pada HFpEF ya. Kalau dulu mungkin HFrEF yang paling populer sekarang, tapi dengan kemajuan obat-obatan yang signifikan pada HFrEF menurunkan risiko hospitalisasi, sedangkan HFpEF sampai saat ini terapinya masih banyak yang belum limited evidence ya outcome-nya, sehingga makin lama makin naik Lebih dari 50% pasien hospitalized dengan heart failure itu biasanya karena HFrEF. Dan kalau kita pikirkan dulu mungkin ini HFrEF jauh lebih ringan lah daripada HFrEF. HFrEF fungsi jantung lebih rendah sehingga mortality rate-nya lebih tinggi. Tapi kenyataan data menunjukkan bahwa tidak banyak terlalu ada perbedaan, similar, mirip lah, antara mortality yang disebabkan oleh HFrEF maupun dengan HFrEF. Sehingga ini menjadi masalah. Lagi-lagi tadi Dr. Maya sudah menyampaikan berbagai obat yang menunjukkan signifikan outcome, menurunkan dari hospitalisasi dan mortality pada HFrEF, tapi pada HFrEF saat ini masih limited proven terapinya ya. Jadi pilihan terapinya nggak terlalu banyak sehingga ini tetap menjadi masalah. Lalu gimana? Apakah HFrEF dan HFrEF ini adalah suatu subset kontinuum yang sama? Yang mana dulu pahamnya HFrEF atau HFrEF ini adalah suatu perpanjangan dari HFrEF ya, karena makin lama gangguan hipertensi makin berat, sama lama pasien fungsi jantungnya rendah. Tapi kenyataannya makin banyak studi dan data-data menunjukkan bahwa ini adalah dua entiti penyakit yang berbeda. Ini salah satu studi yang cukup baik, dia mengikuti 126 pasien dengan HFrEF selama hampir 14 tahun. Dan di sini dia menunjukkan hanya 1,6% pasien-pasien HFrEF yang sebenarnya nantinya akan evolve, akan berubah jadi HFrEF. Jadi menunjukkan sebenarnya ini entitasnya kemungkinan berbeda. Dan data ditunjang lagi dengan penelitian dari Han dan kawan-kawan dipublish di Circulation 2021 bahwa ternyata memang betul HFrEF dan HFrEF ini secara genetik variansinya berbeda. Kita bisa lihat yang warna hijau ini sebagai kontrol, dan HFrEF itu yang sebelah kiri yang orange, dan HFrEF itu yang kanan. Genetiknya, polaritinya berbeda sama sekali. Jadi ini merupakan suatu dua penyakit yang berbeda. Mungkin di tengah-tengah ada yang overlapping, tapi kenyataannya ini adalah dua penyakit yang berbeda, sehingga kita harus mengenali. Dan terapinya nanti mungkin akan dibicarakan oleh Profesor David Sims. Dan Han dan kawan-kawan membuat klasternya berdasarkan genetik dan klinikalnya. Di sini dia membaginya di grup 1 sampai 3. Di mana grup 1 itu kita lihat survivalnya paling jelek ya dibanding yang lain. Dia predominannya male, diabetes, low BMI, NT-proBNP-nya lebih tinggi, jantungnya lebih besar. Nah, ini sebenarnya gambarannya mirip dengan secara gene itu mirip dengan HFrEF. Tapi yang menarik di grup 2 ini konsisten hanya pada female. Jadi menunjukkan adanya sex difference pada pasien-pasien HFrEF juga pada subset populasinya. Biasanya female ada high BMI-nya, obesitas, jantungnya nggak besar, kecil. NT-proBNP bisa kecil, lowest NT-proBNP-nya, tapi inflammatory levelnya tinggi pada grup yang 2 ini. Dan juga ada aktivasi gene OXPHOS gene ini untuk oksidasi fosforilasi biasanya pada pasien-pasien obesitas, ada down regulasi dan autofagi, angiogenesisnya kurang, dan ada oxidative stressnya juga terjadi. Grup 3 lebih heterogenitas, ini diantaranya, jadi tapi dia tetap lebih mirip ke grup 2, grup 2 karena ada peningkatan gen-gen dari obesitas dan angiogenesis kurang. Yang lain gimana? Ini kan secara genetik. Saya mau menampilkan lagi bahwa HFrEF ini memang susah untuk dilihat karena clinical phenotype-nya banyak. Ini dari studi Sweden Heart Failure Registry, dia menggunakan klinis diagnosisnya, yaitu dia membagi jadi 5 klaster. Ya, klaster pertama ini didapatkan pasien-pasiennya young, low comorbidities. Tapi sebenarnya kalau dibilang young pun mediannya 59 tahun sebenarnya. Jadi memang jelas HFrEF itu berhubungan dengan usia ya. Stress inclination-nya male. Nah, ini menarik pada pasien-pasien ini low NT-proBNP sebenarnya. Jadi mungkin udah ada keluhan klinis heart failure, tapi sebenarnya secara pemeriksaan semuanya masih dalam batas normal gitu ya. Dan tapi event risk-nya masih paling rendah dibandingin yang klaster yang lain. Yang 2 ini lebih tua. Nah, udah mulai 77 tahun. Biasanya berhubungan dengan aging, ada atrial fibrillation dan hypertension sebagai masalah utamanya. Ini dominasinya di male, tapi dia normal GFR dan biasanya nggak ada diabetes. Jadi pure hypertension and atrial fibrillation. Ini event rate-nya 35,%.
Recording in progress.
Penelitian banyak yang netral ya tadi bilang, tapi beberapa sub analisisnya menunjukkan kalau kita lakukan phenotyping sebenarnya mungkin penelitian-penelitian tersebut bermakna pada beberapa subset tertentu. Contoh ini adalah data dari Top Cat Study, di mana setelah dia melakukan awalnya tidak bermakna pemberian spironolactone pada tidak bisa menurunkan mortality and hospitalization pada pasien-pasien heart failure persistent ejection fraction, tapi setelah dilakukan phenotyping ternyata kita bisa lihat setelah di phenotyping jadi 3 grup bahwa spironolactone sebenarnya bisa memberikan perbaikan pada pasien-pasien yang phenotype dengan obesitas atau diabetes atau yang masuk klaster tadi klaster 4 ya. Jadi itu pentingnya nanti ke depannya mungkin future trial perlu dilakukan phenotyping dan teman-teman mesti tahu bahwa clinical phenotype dari HFrEF ini banyak ya. Mekanismenya apa? Masih banyak yang belum diketahui, tapi saya coba rangkum aja dalam ada 6 besar ini. Pertama ada left atrial filling pressure. Ini sebenarnya left atrial filling pressure, pulmonary vascular disease, volume overload itu sama kurang lebih, yaitu ada left heart disease dengan gangguannya menyebabkan gangguan left atrial filling pressure dan akhirnya kongesti. Tapi ada gangguan-gangguan lain seperti inflamasi, microvascular inflammation yang berpengaruh, ada metabolik tadi, obesitas, diabetes yang juga akan berpengaruh pada HFrEF, dan adanya perubahan struktural seperti LVH konsentrik, dia dari extracellular changes-nya ganti sehingga menjadi stiffness pada pasien-pasien dengan HFrEF. Kita masuk sekarang setelah mengetahui banyak ternyata clinical phenotype-nya banyak banget ya HFrEF itu tadi berbagai klaster, kita akan coba diagnostik. Diagnosisnya sebenarnya ada 2, tapi yang kita bicarakan dulu pertama adalah HFrEF, di mana dia pertama menggunakan HFrEF. PrEF itu adalah kita dengan preterm assessment untuk heart failure probability. Kita dengan melihat clinical history-nya. Ada nggak? Tadi kan heart failure kita kembali definisi ada sindrom klinis. Jadi kita harus lihat sindrom klinisnya, ada tanda-tanda heart failure dan ada tanda-tanda riwayat jantung juga yang bisa mendukung tadi komorbiditasnya. Lalu physical examination juga cocok dengan karena heart failure, ada RAILS, ada bilateral edema, mungkin ada murmur, ada elevated jugular pressure sehingga masuk kalau ada satu aja kita bisa lanjut pemeriksaan lanjutan, bisa kalau senternya ada natriuretic peptide bisa kita cek, atau kalau enggak kita bisa langsung ke ekokardiografi kan. Ini sayangnya penting tetap untuk pada pasien-pasien HFrEF karena kita harus tahu sebenarnya ejection fraction-nya berapa. Kalau misalkan enggak ada sama sekali yang mengarah ke situ proses probability, mungkin kita pikirkan penyebabnya adalah yang lain ya. Selanjutnya ini tadi setelah kita melihat probability heart failure-nya ada, kita lanjut ke step E. E itu adalah echo. Di mana echo kita menentukan nanti adalah skornya adalah high, intermediate atau low. Ya, nanti akan kalau misalkan high, misalkan HFrEF udah confirm, tapi kalau intermediate kita harus lanjut ke step untuk stress test ya, entah dengan non invasif atau invasif. Dan selanjutnya adalah kita cari etiologinya. Ini dari yang step E, echo-nya yang kita nilai nanti adalah ada functional. Kita melihat septal E prime, lateral E prime, atau E per E prime menunjukkan left atrial filling pressure, atau TR velocity yang menunjukkan ada pulmonary vascular hypertension. Lalu kita morfologinya, kita melihat tentunya struktur dari LV MI-nya, concentric hypertrophy-nya, dan juga ukuran dari left atrial yang menunjukkan adanya chronic atrial pressure di situ. Dengan biomarkernya sendiri, dia bisa gunakan NT-proBNP atau BNP. Biasanya kita bagi 2, kalau atrial fibrillation dia mengambil limit yang lebih tinggi. Intinya kalau misal skornya akhirnya mencapai 5, maka diagnosis HFrEF bisa ditegakkan. Kalau 2-4, kita lanjut ke step berikutnya, yaitu stress test. Nah, stress test ini bisa dengan non-invasive, bisa dengan echo. Kita mau cari intinya dia E per E prime-nya naik nggak, filling pressure-nya naik nggak. Kan kadang-kadang pasien keluhannya cepat capeknya saat aktivitas, makanya kita lakukan stress echo, yaitu saat aktivitas sesuai dengan keadaan pasien. Kalau misalkan ada peningkatan E per E prime atau air velocity-nya meningkat, berarti kita nambah poinnya dan kemudian kita bisa mendiagnosis sebagai HFrEF. Kalau enggak juga, kita lanjut invasif sebagai gold standarnya. Kita bisa lihat invasif benar-benar ada di situ peningkatan tekanan left atrial filling pressure dan menunjukkan PCVP-nya lebih dari 15. Ini dari HFrEF. Cukup rumit sebenarnya ya. Selanjutnya mungkin ada yang lebih simple, yaitu H2FrEF. Ini another HFrEF diagnostic algorithm, mungkin lebih simple, tapi sebenarnya Kalau dibanding HFrEF sebenarnya ini dibuat standarnya berdasarkan suatu invasive study, sedangkan HFrEF sebenarnya validated karena expert opinion. Jadi walaupun dia lebih simpel, tapi sebenarnya dia dibuat dengan parameter yang ada dari invasive study. Pertama lebih simpel mungkin heavy body mass index, mulai poinnya 2, hypertension, poinnya 1, atrial fibrillation ini sangat tinggi, poinnya 3, pulmonary hypertension 1, elder 1, usia lebih 60 dan feeling pressure juga 1, cukup 9 aja udah cukup. Dimana kalau misalkan ada total poinnya 9, maka probability HFrEF-nya lebih dari sebesar 95%. Jadi mungkin lebih simpel dan bisa kita gunakan kalau pasien-pasiennya di center yang mungkin nggak ada NT-proBNP. Nah, kita harus bandingkan, ternyata ada studi yang menunjukkan perbandingan antara HFrEF sama H2FrEF gimana sih? Untuk menilai ini, di sini dia bisa menyingkirkan unaspected dyspnea, tapi ternyata duanya ini agreement-nya antara keduanya hanya sebesar 4%, kita bisa melihat. Dan kenyataannya bahwa HFrEF dan H2FrEF menunjukkan subpopulasi yang berbeda, ya. Jadi mungkin bisa dilihat dengan gambar ini, kalau misalkan dia dua-duanya rendah probability-nya, maka kita lihat yang warna biru dia risiko heart failure-nya paling rendah. Tapi kalau jelas kalau dua-duanya tadi yang masuk 4%, skornya dua-duanya tinggi, maka dia risiko hospitalisasinya paling tinggi. Nah, tapi yang menarik di sini kalau misalkan salah satunya rendah, misalkan kita cuma pakai HFrEF saja, ternyata HF2FF-nya yang tinggi, itu risiko heart failure hospitalization meningkat. Jadi kita ada kemungkinan untuk misdiagnosis untuk HFrEF kalau kita hanya menggunakan salah satu saja. Begitu pula sebaliknya kalau kita menemukan HFrEF-nya tinggi, ternyata HFrEF-nya rendah, juga sama risikonya kurang lama meningkat. Jadi mengingat clinical phenotype-nya banyak, sebenarnya mungkin akan lebih baik kalau bisa kita kombinasikan kedua algoritma ini. Jadi di situ kesulitan dari diagnosisnya. Mungkin saya sebagai konklusinya atau take home message-nya, HFrEF have become major cardiovascular threat ya in recent years. Jadi kita lihat proporsinya meningkat, mortalitasnya juga tinggi, sehingga dia benar-benar menjadi masalah ya untuk kita saat ini. Lalu kita udah tunjukkan tadi fenotype dan genetiknya banyak banget heterogeneity-nya. Tadi ada yang karena obesitas berkaitan dengan klaster dengan diabetes, obesitas atau atrial fibrillation. Jadi ini mungkin perlu kedepannya perlu dilihat subclade phenotype-nya ya. Lalu kedua HFrEF dan H2FrEF ini punya dua subpopulasi yang berbeda. Jadi kalau kita gunakan salah satu saja, ada kemungkinan miss nggak? Ada mungkin ya. Sehingga kita perlu lihat secara pasti pasiennya secara klinis ya, secara risiko, dan kalau bisa digunakan keduanya akan lebih baik. Dan yang pasti inilah tadi future trial harus dilakukan sesuai dengan subphenotype. Karena banyak phenotype HFrEF ternyata bermakna bila pasiennya itu cocok di subphenotype tertentu. Contoh tadi Topcat trial di pasien-pasien obesitas dia bermakna, tapi tidak di jenis HFrEF yang lain. Sehingga kita bisa mendapatkan treatment responnya secara lebih homogeneous. Mungkin sekian presentasi dari saya, Dr. Riri. Atas perhatiannya saya ucapkan terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Hari Sakti Mulyawan, for the very clear, simple, and very nicely done by both presentations by Dr. Maya and also by Dr. Hari. And so we come to the last but not least, our distinguished guest, Dr. David Sim. David, how are you?
I'm fine, yeah.
Okay, so I don't think I need to tell everybody who he is actually. He's is a very popular heart failure specialist. And this is, I believe, where Dr. Maya was trained as a heart failure specialist. So, Professor David Sim, without further ado, the time is yours to deliver your lecture.
Thank you very much. Yeah. So let me share my screen first. Sorry, I'm having problem sharing. He said I can't share my screen because somebody's sharing screen now. Can the IT team let me share my screen?
fraction.
Right, thank you very much for the kind invitation. Just to confirm, can you see my slide? Sorry, just to confirm, can you guys see my slide? Yeah, so I'm going to start. Today, I'm given the topic of HFpEF treatment. What does the latest evidence tell us? So besides talking about SGLT2 inhibitor as the treatment of HFpEF, I'm going to also talk about the treatment of HFpEF with other agents as well, some of the earlier study as well. So these are my declaration of interest. As the previous speaker has pointed out, nowadays, the definition of heart failure can be broadly divided into 4 different classes. It is reduced ejection fraction, less than 40%, between 41 to 49. Previously, we may have known it as heart failure with mid-range ejection fraction. Now we have changed it to mildly reduced ejection fraction. And lastly, we have the heart failure preserved ejection fraction with a ejection fraction of more than or equal to 50%. And lastly, not to forget, this group of heart failure with improved ejection fraction, that is, they previously had an ejection fraction of less than 40%, but after treatment with all the medication, they do improve more than 40%. So please do not label somebody, for example, previously with 30-something, 20-something%, and after treatment, recover back to 50% above. This group should not be classified as HFpEF. They are heart failure with improved ejection fraction. And why are we so interested in heart failure with preserved ejection fraction? As we know, they are exactly the same like heart failure with reduced ejection fraction in terms of mortality and morbidity. It causes a lot of heart failure hospitalization. In fact, heart failure is the #1 cause for heart failure for hospitalization in elderly patients more than 65 years old. And unfortunately for us, which I'm going to show you later, until recent year, there was actually no clinically proven therapy available to this group of patients HFpEF to reduce their heart failure outcome. And we know that in HFpEF, like what the previous second speaker has told us, that just like heart failure with reduced ejection fraction, it's not one single mechanism that caused the disease. As you can see here, many different things can go wrong in heart failure with HFpEF. They have, structural changes such as impaired, LV relaxation, increased atrial size, and also left ventricular hypertrophy. At the same time, they do get a lot of neurohormonal imbalances as well, a lot of fibrosis as well. And for us in heart failure, we know that a lot of time is due to the RAS overactivity. And also in recent years, we have more insight into natriuretic peptide system as well, the role of BMP in heart failure as well. Of course, there are other familiar systems, such as previously earlier today, we talked about beta blocker, its impact on the synaptic system. And as a result of all these different systems that can go wrong, one of the possible agents that was previously being considered for treatment of heart failure with preserved ejection fraction HFpEF was that of the use of ARNI, the combination of ARB and a neprilysin inhibitor to target the natriuretic peptide system that we know is deranged in patients with HFpEF as well. So as we know that the sacubitril valsartan, or in short ARNI, it contains valsartan, a angiotensin II receptor blocker, and also this new agent sacubitril that we know that will increase the BMP, resulting in vasodilation and decreased fibrosis, all the effect that we will want in a patient with heart failure with preserved ejection fraction. So based on this theory, went ahead to plan a Paragon-HF trial with the use of HFpEF, the use of ARNI in the phase 3 trial in patients with ejection fraction defined as more than or equal to 45%. So technically, some of these patients are actually mildly reduced ejection fraction. And it was a phase 3 trial. The comparator was that of ARNI, sacubitril valsartan, 200 milligrams twice a day versus valsartan, 160 milligram twice a day. Primary outcome was a composite of cardiovascular death and total heart failure hospitalization. And these are the key inclusion criteria, very typical for a heart failure trial. We need the patient to have ejection fraction of more than or equal to 45%. They are all patients with symptoms, that is New York Heart Association class 2 to class 4. And in order to qualify, the patient need to have a raised biomarker as measured by the BNP or the NT-proBNP and evidence of structural heart disease within 6 months prior to screening. That is either a left atrium enlargement or left ventricular hypertrophy. And you can see that in more recent years, all the heart failure trials they do emphasize we need to prove that there's structural heart disease before we can recruit patients to the trial. Reason being, in the earlier heart failure trial involving ARB and the spironolactone, they did not specify the patient need to have structural heart disease. And as a result, we suspect some of those trials may have failed because some of these patients that are recruited are not truly heart failure with preserved ejection fraction. They may be just elderly patients with hypertension and obese. And you can see that this is the Paragon HF trial. When you compare the previous trial, I previously mentioned, Top Cat, which look at spironolactone, I-Preserve, and Chum Preserve, that both look at ARB, and also PEP-CHF using the ACE inhibitor. You can see that the main difference is in Paragon HF, in more recent trial, it becomes compulsory to have a combination of elevated biomarker and structural heart disease on echo. Unfortunately, for the Paragon HF trial, the primary endpoint was not met, as you can see here. The p-value was not significant at 0.059 for cardiovascular death or total heart failure hospitalization. And in terms of cardiovascular death, there was absolutely no difference. In terms of the heart failure hospitalization, there was a trend toward lower heart failure hospitalization in those patients taking an ARNI, but unfortunately, it did not reach statistical significance. And we look at primary endpoint in subgroup analysis. Very interestingly, two groups became, was of interest came out. The first was the gender. Female patient tend to respond better than male patient. And lastly, the cutoff of the ejection fraction. Patient with ejection fraction of less than 57% tend to respond, whereas those patients with an ejection fraction of more than 57%, they tend to not to have effect. So now looking at another trial, the Top Cat trial, using spironolactone, again in patients with ejection fraction more than or equal to 45%, we do see the same trend like in the Paragon HF trial. That is, those patients with a lower ejection fraction in the mildly reduced range, less than 50%, they tend to respond. Whereas as the ejection fraction becomes higher, above 50%, above 55%, then we start to see the effect tend to wear off. So you can see here, looking at the different quartile of ejection fraction, the patient who responded the best were those with ejection fraction between 45 to 50. Once it go up to 50 to 55, the effects sort of wear off. By the time they are more than 55%, you can see that there's literally neutrality. There's no difference. So we do have also some data of the ARB in our patient with heart failure with ejection fraction more than 40% as well. As you can see here, again, we see a very common trend. That's like the Paragon HF trial and the Top Cat trial. In a Chum Preserve, you can see that when the ejection fraction is less than 40%, the drug works. But when it is between the 40 to 49, the mildly reduced ejection fraction, again, it works. But once it crosses over 50%, the truly preserved ejection fraction, that's where we see the p-value become not significant. So now I'm going to move on to the highlight of today, the mainly SGLT2 inhibitor, talking about the Emperor Preserve study that was presented last year. Emperor Preserve study is, you think of it as the HFrEF equivalent of the Emperor Reduce that Dr. Hawani has presented earlier today. Essentially, same design as the Emperor Reduce, looking at empagliflozin versus placebo, except in this case, we are interested in the preserved ejection fraction. Strictly speaking, the Emperor Preserve trial is not just about heart failure with preserved ejection fraction, because its ejection fraction more than 40%, we capture those between 41 to 49 as well. So it is actually a trial of mildly reduced and preserved ejection fraction. So these are the patients that were recruited. We are looking at patients with ejection fraction more than 40%, with an NT-proBNP that is raised at the same time. They need to have structural changes as well. Very well matched kind of baseline. Essentially, elderly patient. We see quite a fair bit of number of women in HFrEF trial as well, and good representation from Asia here as well, slightly more than 10%. And importantly, we have a good mix of patients in the different heart failure quartiles. We have between the 40 to 50%, the 50 to 60%, and the more than 60%. So actually about 1/3 of patient is actually mildly reduced ejection fraction. Good mix of non-ischemic as well, and also quite a fair bit of patient with atrial fibrillation, up to 50%. Only half of the patient have diabetes. And in terms of EGFR, average EGFR was 60 mils per minute. And in terms of cardiovascular medicine, you can see here, quite a lot of patients, about more than 80% were on a RAS inhibitor or ANI. MRA usage was close to 40%. Beta blocker usage pretty high as well, up to 85%. So this was the primary endpoint that we're interested in, essentially cardiovascular death or heart failure hospitalization. And the two secondary endpoints was specified. The first one was looking at recurrent heart failure hospitalization, and the next one was looking at the deterioration in the EGFR, interested in the renal function. So fortunately for us, for the first time in the heart failure with preserved ejection fraction, we do have a positive trial. The EMPEROR Preserve was the first trial to demonstrate a significant p-value of, and with a hazard ratio of 0.79. That is, the taking of empagliflozin is associated with a 21% reduction when compared to placebo in reduction of cardiovascular death or heart failure hospitalization. And importantly, this was achieved as early as day 18. So the effect of the drug is within 3 weeks. And when we look at the interaction that we see in Paragon HF, fortunately in the EMPEROR Preserve, we do not see that interaction. Both male and female patients responded equally well to the drug. And you can see further down, in terms of the different region, Asia patient also responded equally well. If not, Asia patient actually have the lowest hazard ratio, responded the best to the drug. And in terms of the ejection fraction that we see in the TopCat trial, CHARM Preserve and the Paragon, where we see the higher ejection fraction do not respond, in the EMPEROR Preserve, you can see that from less than 50% to those patients more than or equal to 60%, the p-value for interaction was not significant. That is, the drug worked across the whole continuum from 40% and above. And in terms of the baseline use, regardless of those patients, whether you are using ACE, ARB, or ANI, or we are using MRA, or looking at the blood pressure, or whether they have atrial fibrillation or not, we do not see a difference. The subgroup analysis is quite consistent. All different group of patients do respond to the drug. And in terms of the heart failure with recurrent admission, again, it was statistically significant with a 27% reduction in heart failure recurrent admission. And importantly, the use of the drug was also associated with a slowing down in the decline in the kidney function. As you can see here, as we're familiar, the use of SGLT2 inhibitor, when we first use the drug, it will cause an initial drop in the EGFR. That is to be expected and no need to be, when you use this drug, do not be alarmed when you see a drop in the EGFR. That is just the way the drug works. But importantly, over the long run, the drug actually prevents the further deterioration or slow down the deterioration in the renal function by slowing down the decline in the EGFR compared to placebo. So this is a summary of the endpoint for the EMPEROR Preserve. Primary endpoint, there's cardiovascular death or heart failure hospitalization was met. The two key secondary endpoints, that is first and recurrent heart failure hospitalization, and the drop in the EGFR slope was all met as well. What about mortality? Do we see any mortality benefit? The changes in the primary endpoint was mainly driven by a reduction in heart failure hospitalization. In terms of mortality, it was neutral. But do take note that up to half of the death was actually due to non-cardiovascular cause. So I think in a HFpEF patient, probably a bit hard to prevent total mortality because this is an elderly patient and a lot of deaths are actually not due to cardiovascular cause. So a bit hard to expect a cardiovascular drug to cause a drop in non-cardiovascular cause. In terms of the labs wise, you can see a slight drop in the NT-proBNP, but not very significant. In terms of HbA1c, there was also only a slight drop, so no concern in terms of causing massive drop in HbA1c, especially among those patients without diabetes causing hypoglycemia. Adverse event, you can see here, very similar between placebo group and the group taking the empagliflozin, so there's no concern here. And in terms of hypoglycemia, there was actually no difference between those patients taking the drug and those patients not taking the drug. So to summarize, the EMPEROR PRESERVE is a first study in HFpEF to meet its primary endpoint. In the last 20 years or so, we have tried, from a CHARM PRESERVE to TOPCAT, Paragon, nothing actually works. So far, all the trials has been negative or neutral. So to summarize what we have gone through today, earlier in the day, we heard about a talk on reduced ejection fraction. As you know, in reduced ejection fraction, we are quite lucky in the field of heart failure. We have at least 4 or 5 different classes of drug that we can use in a heart failure reduced ejection fraction. But for only reduced or preserved ejection fraction, unfortunately for us, we have tried over the last 20 years, nothing has worked so far until the recent publication of the EMPEROR PRESERVE, the first and so far only positive trial in heart failure with preserved ejection fraction. What about those patients who come with acute decompensated heart failure for HFpEF or HFrEF? Can we start the drug early? Answer is yes. We do have now data, this from an MPulse study, that is interested in looking at acute heart failure patients, both HFrEF and HFpEF. So essentially, these are patients with heart failure who get admitted to hospital, and between 24 hours to the 5th day of admission, we are able to start them on the SGLT2 inhibitor and empagliflozin early. Of course, the patient must be stabilized first. That is, they cannot be on inotrope. They cannot be on intravenous diuretic when we start them on the empagliflozin. As I pointed out previously by the first speaker, Dr. Hawani, she has shown this before. The early use during inpatient acute decompensated heart failure of empagliflozin versus placebo was associated. Those patients treated with empagliflozin was 36% more likely to experience a clinical benefit in terms of time to death, in terms of heart failure event, such as heart failure hospitalization. And so with all this data from EMPEROR PRESERVE to EMPEROR REDUCE, we now have updated the guideline, showing this from the European Society of Cardiology. So you can see that on the left side, that is the mildly reduced ejection fraction. Most of the drug only got a class 2B indication because of the lack of evidence. Unfortunately, because of the EMPEROR PRESERVE study was only released during ESC when the guideline came out together, there was no time to incorporate it into a guideline. But what you can see on the right side is the preserved ejection fraction, the European Society, nothing was actually recommended. But earlier this year, the ACC/AHA guideline, the American guideline, they did incorporate it. They do have the time to incorporate the latest EMPEROR PRESERVE study into the guideline. You can see that for both mildly reduced and for preserved ejection fraction, SGLT2 has been given a class 2A indication, probably based on the EMPEROR PRESERVE study, whereas the other agents such as ACE, ARNI, MRA, they are given the class 2B because of neutral trial previously. So we now do have a class 2A indication for treatment of patients with ejection fraction of more than 40%. With that, I end my talk. Thank you very much.
Thank you, Dr. David Sim, for the very nice presentations about HFpEF and the management of HFpEF with the current proof from EMPEROR PRESERVE that just released early this year. Yeah. So we're going to move on to the Q&A. We have quite a lot of questions here asked to the presenters. One of the questions were already answered by your presentation, David. So I will not be reading that question anymore. And there's this intriguing questions regarding the glucose effect of SGLT. There's this question about how does it affect the glucose control in patients with diabetes, because this physician here has some sort of like a reluctancy from the endocrinologist to use SGLT2 as the first line therapy for patients with diabetes. I think I should ask Dr. David Sim first, and then Maya maybe. David?
Yeah. So when we use a drug such as a empagliflozin for the treatment of heart failure patient, we understand that the main reason why we're using it is because of the cardio protection, the heart failure protection, and also the renal protection that is shown. It actually slows down the slope of the eGFR decline. So that is a key thing, cardio-renal protection. For the diabetes part, it depends. For those patients with diabetes, I find that it does work, it does bring down H1C. But for those patients without diabetes, there's no concern of hypoglycemia. When the patient is not diabetic, we don't see a high sugar count. They actually do not the drug do not have a very great HbA1c lowering in those patients with normal sugar level. At the same time, also do take note that in our heart failure patient who usually have cardio-renal syndrome, when the eGFR is a bit on the lower side, that group of patient, the lower the eGFR, the diabetes or the sugar lowering effect also become muted, not as strong as well. So a bit unlikely to cause hypoglycemia as well. So my own personal preference is for patients with diabetes, good. I start a drug, I get 3 benefit: cardio benefit, renal benefit, and also lower sugar. For those patients without diabetes, but they have heart failure or kidney problem, I do start the drug as well because I still get the cardio and renal protection, but not at the risk of hypoglycemia.
In clinical practice, the blood glucose effect of SGLT2 is not as high as other, so that's why they don't really reduce the blood pressure level to some extent. I think that's what the reluctancy lies from the endocrinologists. But I don't know, Maya, what do you think?
Yes, indeed, empagliflozin is probably not reducing the A1C level that low. I mean, comparing to other anti-diabetics agents. But in terms of the cardiovascular outcome, improvement in cardiovascular outcome, and especially in heart failure hospitalizations, I think the reduction is not related to A1C level. Although the A1C level is not that low, but in terms of the cardiovascular outcome and heart failure hospitalizations, the results is tremendously high. I mean, the reduction is tremendously high in terms of cardiovascular outcome and also heart failure hospitalizations. And we know that we also call it the SGLT2 inhibitor has a pleiotropic effect. So it's not only related to the A1C reductions, but it's more than that. It's more than that. So, I mean, in terms of if you have patients with, we know that now the indications to give SGLT2 inhibitor in diabetes patients is as long as your patients have multiple major risks, cardiovascular risks, I mean multiple cardiovascular risks, and then your patients have heart failure, either heart failure reduced ejection fractions or heart failure preserved ejection fractions, that's an indications to use SGLT2 inhibitors, not only related to the reductions of the A1C level. We go for the pleiotropic effect. I think is my answer, Dr. Ri. Thank you so much.
Quite clear. So we go beyond blood glucose lowering. So yes, it's for the renal protective effect, the cardio protective effect, and also as the blood glucose. So it's not just simply blood glucose lowering agent. Okay. And the second question goes to Hari and also to David. In the practical thing, how do we diagnose HFpEF? Because you can have a lot of schemes in diagnostic HFpEF, the H2PF, HFpEF, blah blah blah. And how is it that we can do for those general physicians who are not really very well equipped? How would they just simply diagnose HFpEF? Is it simply just the sign and symptom is there with a normal ejection fraction, and then we can put this patient into HFpEF group or something? Hari, and then maybe Dr. David Sim after that.
Okay, thank you very much, Dr. Riri. So I think in setting of low resource, I think for general physicians in the rural area, we have to go back to the division of heart failure. We have to emphasize that heart failure is a clinical syndrome. So clinical syndrome, apparently, actually, to diagnose heart failure is more easy because we know by clinical symptoms and clinical signs and symptoms that more and history of cardiac problems, patient have diabetes or atrial fibrillation, this goes, we can diagnose as heart failure. But more difficult is whether to diagnose, specifically preserve ejection fraction. Of course, we have to know the ejection fraction by echocardiography. And I think we can use a simple method to check the maybe little bit difficult for diastolic dysfunction. At least using simple symptom and sign, at least like H2FF algorithm is rather simple, not like F2PF. And you can use it just by seeing the patient whether they have a symptom and signs of heart failure and have a comorbidities like obesity, diabetes, or atrial fibrillations that can high likelihood to get the probability for heart failure. And at least the patient have ejection fraction. Maybe general physician not yet enough skill to detect LV diastolic dysfunction, maybe a little bit difficult, but at least just only symptom and sign to heart failure. Come back, we can diagnose this patient. Prior test probability heart failure is increased. Have multiple comorbidities like diabetes, atrial fibrillation especially, and patient already older enough, and ejection fraction is normal. We can also diagnose it with as a HFpEF. Yeah. Yes.
Yeah, so for HFpEF, it's a bit more tricky, unlike the HFrEF. So the first thing I always look at is to diagnose somebody HFpEF, look at the demographic of the patient. Somebody who is young, 20, 30 years old, obviously, I'm not going to diagnose a patient having HFpEF. Usually, most of these HFpEF patients are more elderly, and they have certain features such as more likely to have hypertension, atrial fibrillation, and obesity as well. I personally am not a big fan of the H2PEF score from America. I tend to follow more European because based on the American score, actually it's very easy. All you need to have typical signs and symptoms of heart failure, obesity, a bit of comorbidity, atrial fibrillation. You can be diagnosed with HFpEF. That will result in a lot of patients who are just obese with fast atrial fibrillation to be diagnosed with HFpEF. Because don't forget, poorly controlled atrial fibrillation can also present a heart failure, but they're not truly HFpEF. So I prefer the European way where we are a bit more objective, where we need to have the biomarker and the structural changes on the echo. So it's a bit hard for me to say somebody HFpEF if the NT-proBNP come back as normal, or there's absolutely no structural changes. You don't see LVH, you don't see LV filling pressure being elevated, or you don't see LA dilatation on the echo, see. And lastly, for some patients who really, we cannot figure out what's going on, I will actually do a stress echo for them. And during a stress echo, I'm actually not looking for ischemia. I'm actually looking for a rise in the pulmonary pressure. So at rest, the patient may have a normal feeling pressure, but after exercise, I see a elevation in the feeling pressure or elevation in the pulmonary pressure. That is also another way of diagnosing HFpEF as well. Or very seldom do I bring the patient to a cath lab to do a bicycle, on the bicycle so that I can do a right heart study to see after at rest and after exercising, they are, wedge pressure actually go up. So this is how I diagnose the patient. And also importantly, during doing an echo, please do note the feature echo. Look out for mimickers of HFpEF. Quite a fair bit elderly patient with HFpEF. Actually, in Singapore and I think globally, we actually now find out that they actually turn out to be cardiac amyloidosis. So that is a totally different group of patients.
Okay, great. Thank you, David. So basically, it's not really that complicated if you want diagnose and HFrEF patient. Just basically, the sign and symptoms is there with a few comorbidities is there, so we can simply, okay, this is patient is should be put into the HFrEF patients, just like Harry and David has already mentioned. Okay, this one is a very, just come up to my screen. Sorry. What is your opinion about the issue of emperor-preserved result that was largely driven by the reduction in hospitalization and heart failure hospitalization instead of its effect in reducing mortality? So, David, I think it
Yeah,
is
so as I previously mentioned, I know this question will definitely pop up. You remember one of my slide I put out there as the 50% of the death in emperor preserve was due to non-cardiac. Because not to forget, these are very elderly patients who may die from other causes such as infection, pneumonia, cancer. So it's a bit hard to expect a cardiovascular drug to reduce all these non-cardiac kind of death. So that's one of the possibility. And the other thing to take note is in a patient who is elderly in the 70s and 80s, I think the important thing for this group of patients to me is better quality of life, less heart failure hospitalization for this group of HFpEF patient. The aim may be very different from a young patient with HFrEF who we want to live much more longer. Because you think of it, if I have an 80 years old HFpEF patient, the aim should be between 80 to maybe 83, 84 to keep him as much as possible out of hospital, better quality of life, rather than saying I want to increase the lifespan at 80 years old to 100 years old, which is we know is not possible. It's just a natural lifespan of mankind. Yeah.
Agree with you. The less the patient got hospitalized is the hopefully a longer life they will experience. I think that's pretty obvious. Harry, have you any comment on this result of emperor preserved?
Yes, yes. I think, yeah, same like Professor David. Seems that that there's also some hypotheses that show that HFrEF actually is a multi-organ inflammation, so it's really difficult. And most of a lot of patients with HFrEF actually related mortality is because other organ, not only cardiovascular. So it's a little bit difficult to see whether this one drugs can affect and can clear all the problems in other organs. So I think by reducing heart failure hospitalizations is already very good actually, because no other drugs actually up until now proven to reduce hospitalization. So yeah, at least now we have a hope in those patients in to reduce heart failure hospitalization, improve quality of life, and we hope we can also later on and reduce the cardiovascular death in the long term.
Yeah, because I think quality of life is the major aim of any heart failure patients, regardless the ejection fraction. Okay, I think one question to Maya here. Sure, sorry.
A little bit comment actually, Dr. Riri, if you don't mind. Actually, I would just want to ask, it's not a comment, probably it's just questions, but to make sure that everyone in here know which group of patients, Prof. Sim, which group of HFpEF patients that you used to give empagliflozins? I'm just very curious because now we have emperor preserve study. Once when I in Singapore, we don't have the emperor preserve. So I just wondering which group of HFpEF phenotype patients that you will start empagliflozins. Thank you so much.
Yeah. So in Singapore, what we do for the let's talk in heart failure patient in general. So because we have the emperor reduced to the preserve study in Singapore, our practice is as long as the eGFR is more than 20 and the patient have heart failure, regardless of the ejection fraction, it can be as low as 10% to somebody with 60%. We will actually, and the patient of course must have symptom, we will actually use the SGLT2 inhibitor for this group of patient. So for the HFrEF, we have the option of dapagliflozin and empagliflozin. For HFpEF, that's 40% and above. We only need the option of empagliflozin because there's only one approved in Singapore for now. So we do not really look at the ejection fraction anymore because you think of it, the study has shown that across the whole ejection fraction, it works to reduce heart failure hospitalization. It works to increase quality of life. But the key thing is I think is the Blood pressure to me is not a problem. It doesn't cause hyperkalemia. The drug has very little side effect, very easy to start. The only thing we look out for is EGFR. Based on the trial is 20 and above. So we do start patient as long as it's 20 and above, we do start. And do take note that after starting the drug, if the EGFR, example, you start at 25, you start the drug, it drop below 20, it go to 19 and 18, we will still continue the drug in the trial. And in real life, we do continue the drug as well, all the way till they become dialysis dependent.
Okay, so only one measurement, EGFR.
Yeah.
That's it. So I think if you listen to one of the session in ESC HFA just last month, I forgot to say that maybe in future we don't need any ejection fraction anymore. It's just simply heart failure patients. So there's no key importance anymore in whether this patient is HFrEF or HFpEF.
Sorry.
I forgot to say that.
I wanted to add one thing. I do agree that it makes life very easy for us now with the Guardian, across the whole continuum of the ejection fraction, we can use it. But I think we still need echo because, like I previously said, especially for the very, very elderly patient, the reason why we need echo is because sometimes we do pick up some of the abnormal echo that suggests amyloidosis. And when we do further testing, we do pick up amyloidosis. So depending on which series you read, some of the series say that as high as which series are called a patient, sometimes can be even up to 10-15% of the HFpEF patient may actually turn out to be cardiac amyloidosis. So I personally think that for a newly diagnosed heart failure patient, I will still try to get an echo if possible to at least look out for feature amyloidosis, make sure I'm not treating the wrong thing.
Okay, so EGFR and the signs of amyloidosis. Okay, I think that's all for we have today. David, Hari, and Maya, thank you for a very nice discussion. I think we covered all this. We have a couple of more questions, but I think Hari and Maya will answer that in the chat room by themselves. It's okay. David, again, on behalf of the working group, thank you. This is your third time, I believe, with us, the fourth or third time. And I hope I hope you're gonna be there again by the next event next year. Thank you very much, and
thank you
to everybody.
Bye bye.
Thank you very
Thank you,
much.
bye-bye.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.